To get started, when we talk about is there a best treatment for SCAD, many clinicians refer to these two documents. They were both published in 2018. On the left is Sharon Hayes was the senior author on the scientific statement from the American Heart Association, and on the right is the one from the European Society of Cardiology. If there is one thing that we need to take away from the presentation today, at least I believe that these need to be updated because this field, through the efforts of all, has grown tremendously, and we have a lot more information. So, that being said, a patient comes in with SCAD. They have already been diagnosed, so now what do we do? This diagram is from the scientific statement in 2018, and I would point you to the right and to the left. First, on the right, if the patient is unstable, this is where we would consider an invasive approach. And we'll talk more about that in a minute, but for most patients, a conservative course is probably indicated. So let's go to the next. And I have a case presentation as well. And I would underscore what Dr. Ade said earlier. I will tell you that this is a 35-year-old lady, chest pain, had gone, this was when I was in another institution in a different state. She had gone to another hospital the day before. She was, at that time, about 5 days postpartum. She had been diagnosed with myocarditis and sent home. What you're seeing here is that this EKG is not normal. For those of us who look at EKGs, again, not normal. She's fairly tachycardic. She had the troponins checked, as he just pointed in his presentation, and these were elevated. So she's taken to the cath lab, and I just have a still frame here. And what you're seeing is the dissection. While she was on the table in the lab, she had a cardiac arrest. Fortunately, equipment was available and she was quickly resuscitated. I would also point that she does have distal flow preserved if you go further down the vessel. She was marginally perfused on exam. She was hypotensive, tachycardic. She was in shock. So the question then is, what do you do next? Now, we had a series of some not so good outcomes in trying to perform coronary interventions in these patients. And also, I would point you to the literature. This is also from the Mayo Rochester, published in 2014. And what you were seeing are 189 SCAD patients. Now, this was not randomized. This was a retrospective review. Here is what I would point you to. Of the 95 who underwent revascularization, 53% had a procedural failure, 53%. Of the 94 who had conservative therapy, only 10% required revascularization. Now, I realize this is probably not a fair comparison because why did the one group get the revascularization and the other group get the conservative therapy and so on? But most of us would agree that a 53% procedural failure is unacceptable. I would also add that there are some more recent studies that indicate that we have improved somewhat in that area. Now, why is there a low success rate in SCAD? Because we've gotten pretty good now at performing coronary interventions. We can speculate regarding a number of causes, but I would say that the weak vasculature itself is probably what predisposes one to further dissection when performing a cardiac catheterization. Also, as we saw from one of Dr. Ade's films, that the dissection itself tends to occur in medial and further distal vessels, which may be too small for stents. And I like the diagram that we saw earlier, where really we're thinking about SCAD more so as an intramural hematoma. And so if a stent is placed there and you get the resorption of that hematoma, you can get late stent malapposition there. So, by the way, the take-home point is that there are a number of reasons why PTCI is generally not successful in patients with SCAD. So, a picture, I believe, is worth 1,000 words. If you have not seen this before, I want you to pay attention to it, because I've actually seen this in the cath lab a number of years ago when we tried to stent vessels. Shown in A, you clearly see the dissection. A stent is placed, you can see in B, but then look right above the stent. There's the dissection. So what did they do? They stick another stent in there, and it just goes up and up and up, and it's propagated there. So that's fairly frightening when you see this in real time in the cath lab. So we have this patient in our cath lab. She is hemodynamically stable, and there is no way she is going to leave the lab without some type of circulatory support. The decision was made then, and this is not from her study, because again, I was at a different institution. I don't have that slide now, but from a paper, in fact, Dr. Wood, if I'm not mistaken, was a senior author on this paper, where a microaxial flow pump was placed. And this offered circulatory support for several days. The patient recovered, she did well, and went home. So more to come on that one, I believe, in the future. So now we're going to shift and talk about conservative therapy in SCAD, which is where the bulk of this presentation should follow. When we talk about conservative therapy, those of us in cardiology are more comfortable with randomized controlled trials, which is the gold standard of a clinical trial in cardiology. What I have here is a comprehensive list of all published randomized controlled trials in the management of SCAD in the literature. And know this, I didn't leave it out intentionally. There are none, is my point. But we have what we have, and let's go back to 2017. Dr. Saw's group from Vancouver published regarding the risk of recurrence in their population. Now, around that time, I remember we would quote people up to about a 30% chance of recurrence of SCAD after their incident SCAD event. Here is what they found. Now, admittedly, this is a small group. It was only about 327 patients. But let's pay attention. On the left, we have the role of hypertension. On the right, the role of beta blocker treatment. Here is what you see on the left. The hazard ratio, and this is following out to about 7 years, of untreated hypertension is 2.28. So that's quite high. You look here at the risk of recurrence shown in blue with no hypertension, shown in red with hypertension. You have a much higher, what they've shown here is survival free. So I should say survival free is better when the blood pressure is controlled, again, with a hazard ratio of 2.28. So the advice that we should be giving our patients based upon this study is control the blood pressure. On the right, again, this is just from 327 patients. What you are seeing is that the patients who were on beta blockers had a hazard ratio of 0.39. So it has been the standard of care in patients with a history of a SCAD to prescribe and keep them on beta blockers. Again, and that was based primarily on this publication. Now, here's something the same group did a few years later, which is the Canadian SCAD cohort study. Now, this is different. Here is why this is different. This was a prospective study. So these patients were identified and then followed, of 750 patients. Now, here is what I found quite positive in this group. The recurrence rate of SCAD, of a de novo, a new SCAD, was only 2.4%. So this group did much, much better. And the mortality at 3 years was only 0.8%. So again, a lot of hope there. And recurrent MIs, I believe, is about 9.9%. Here is what I want you to see. Shown on the top are the major adverse cardiac events, and shown on the bottom are the recurrent SCADs. Now, one other well, there are several things about this study that I should say, but we're talking about medical therapy here. I should mention that at hospital discharge from their incident SCAD event, 93.7% of these patients were taking an aspirin and 84% were taking a beta blocker. And at 3 years, 80% were still taking an aspirin and 73.5% were taking a beta blocker. So more on this one later. Now, antiplatelet therapy was mentioned earlier. For the clinicians in the room, we know that the guidelines, the non-ST segment elevation MIs, and so on, recommend dual antiplatelet therapy. Many times patients are sent home with stents, and we're not talking about that group. They require a dual antiplatelet therapy. Again, we're talking about conservative therapy here. The DISCO registry evaluated 199 patients. Now, once again, this was not randomized. It was decided whether the patients went home on dual antiplatelet therapy, usually aspirin and clopidogrel, but some of them had ticagrelor instead, or aspirin, and I should say the dose of 81 milligram aspirin. That was decided based upon the physician's choice. So again, that should introduce bias there. Roughly 2/3 had dual antiplatelet therapy. That's going to be shown here in blue, and roughly 1/3 had the single antiplatelet therapy or aspirin 81 milligrams. Here is what you are seeing in the bar graph at the bottom right, shown in the blue. The need for an urgent PCI was 12% in the group treated with dual antiplatelet therapy versus 1.5% in those who were not. Reinfarction, 15% with dual antiplatelet therapy versus 3% with those with an aspirin. And overall major adverse cardiac event, 18.9%, as opposed to the 6% with single antiplatelet therapy or aspirin. What you don't see, there was not a group with no antiplatelet therapy. Just something to think about there. So I'm hoping that I've made the point that we need randomized controlled trials. This I just downloaded in preparing these slides really a few weeks ago from the clinicaltrials.gov site, which is a website of all clinical trials in the US, and there are some North American sites in this study. It says here, not yet recruiting, but I emailed Dr. Alfonso, who immediately responded and told me that they have completed enrollment of the 600 patients, and they're in a 1-to-1-to-1-to-1 group, meaning a quarter of them are going to get aspirin only, a quarter will get beta blocker only, a quarter will get both, and a quarter will get none. So he says that they're performing data analysis. So that should be interesting, and given the finding of the recent Canadian cohort, I hope the sample size is certainly adequate there. I was delighted to hear earlier that cardiac rehab was mentioned, and I'm looking forward to Dr. Phelan's presentation later this morning. But we know that cardiac rehab is underutilized, not only in SCAD patients, but across the board. And there is a mortality benefit in all comers with cardiac rehab. What we see, and this is from speaking with the patients, they believed that they benefited from cardiac rehab, not only from their physical health, but also their emotional benefits. And again, I would underscore that this needs to be considered in every patient who has had SCAD. So to wrap things up on this very rapid tour through medical therapy, I would say that in general, conservative therapy is preferable, but clearly there are some circumstances where that's not enough. We briefly reviewed the role of single antiplatelet therapy, beta blockers, and blood pressure control. more studies need to be done. Because of time, I did not discuss the role or lack thereof of statins and the role of the medications in case there's LV dysfunction, but I'm happy to entertain any of those questions later, or you can always email me too. I also would have as a take-home point that cardiac rehab is vastly underutilized. And I would also say, and I know that Dr. Sumner is going to be speaking later today, that we should not ignore medical treatment for PTSD, anxiety, and depression. And again, if there's one summary statement here, it is that more research is needed, particularly in the area of randomized clinical trials. Those are my thoughts. So thank you.